For those of you in the audience, thank you for making the effort. I really appreciate it. It's good to see some friendly faces. So thank you again for inviting me to your beautiful country and state. And I figured I would start with a picture from where I'm from. So the picture on the screen is Salt Lake City, Utah. And this mountain range is the closest and tallest. This is Mount Olympus, and it's about 9,000 feet, so that'd be right around 2,700 meters for you. But I really like this picture because it's a little bit of an ominous, mountain view. One thing that we're known for in Utah is great snow. And so we had the Olympics in 2002, which was quite an event for us. Okay, so as Wendy mentioned, my name is Thomas Reese. I have a clinical degree in pharmacy and a research degree in biomedical informatics, where I did focus on the human-computer interaction. So my talk will be on how design thinking can put theory into practice. So I'm going to show you how I have and continue to use this iterative process of prototyping and testing to attack some pretty difficult healthcare problems. So at the end of this talk, I want you to leave with just a couple ideas. First, that behavior combined with data can increase the chance of better outcomes, and an appreciation for approaching complex problems with a process and not necessarily a solution. So being from the United States, and the idea that our healthcare system is tightly linked with the litigation system, I figured that I would start off with a malpractice suit where I was called in as an expert witness. So the plaintiff's daughter had suffered a fatal pulmonary embolism that was likely due to a medication she was taking. Now the electronic health record had all the information that was needed to assess this patient's risk factors. And it also had generic information on the medication she was taking and the risks of taking those medications as well. Yet the provider and the pharmacist missed several opportunities to save this patient's life. So from this malpractice case, left me with some unanswered questions. The first was, why was the patient not more aware of signs of clotting? And the other was, why had the provider and multiple pharmacists overridden nearly all medication alerts? Is someone on there? Maybe a question?
It's probably not me.
Okay. Yeah. But really the dissonance from these questions was enough motivation for me to stop practicing pharmacy and pursue further training to try to help clinicians make better healthcare decisions. So shortly after starting my training, I realized that those questions from that malpractice suit were really targeted toward a behavior and were maybe symptoms of larger, more systemic problems. Which brings me to this gentleman, Horst Riddle. So he's a German theorist that mainly worked on engineering and policy-making problems. He coined this term, wicked problems, in the 1960s, which I think this characterization can help explain certain healthcare problems today. So Riddle defined these wicked problems as a class of social system problems that are ill-formulated, where the information is confusing, where there are many clients and decision makers with conflicting values, and where the ramifications of the whole system are thoroughly confusing. So to illustrate how healthcare problems, or certain healthcare problems, are wicked, I'll use something that's near and dear to my heart, which is clinical decision support. So again, tying back to that malpractice case, we pay a lot when litigation happens. So our clinical decision support is really set to be sensitive at that healthcare system level to try to mitigate some of this liability. However, this has unintended consequences. It leaves clinicians distracted. They also develop habits of overriding nearly all warnings. And so the patient has to live with the damages. The clinician is stuck with this liability, while the problem, the root of the problem, seems to be at the system level. So to me, the problems found in that malpractice case seem to be very much wicked. So to further clarify what I mean by wicked problems, these are some of those characteristics. So for every wicked problem, there's always there's also more than one possible explanation. For every wicked problem, it's a symptom of another higher level problem. Solutions to wicked problems cannot be true or false, only good or bad. And wicked problems have no stopping rules. And in solving wicked problems, there is no exhaustive list of operations. And then finally, every wicked problem is unique. So at this point, I hope you're starting to see that certain healthcare problems can be wicked. Now I'm going to jump into how I and others have approached wicked problems. So this brings me to another gentleman, Richard Buchanan. So he's a professor of design and innovation. So he linked wicked problems to design problems. Since in the design space, the problems are indeterminate because the designer really conceives the subject matter. So this makes sense, but what's helpful about linking these wicked problems to design is that these designers have a fairly structured process that really breaks them out of this conventional thinking to find good solutions without this expectation of the right solution. So this is one of those design processes. So the idea is that the process is iterative, reflective, consisting of defining the problem, understanding the users and the environment, ideating, reframing potential solutions, breaking down the solution, and then testing certain aspects. So the goal is to fail quickly and then redefine the problem, go through this process again until the solution is created. But all too often, those in our domain maybe don't have quite the appreciation for this iterative cycle. They tend to skip steps. So sometimes they'll define a problem based on limited information and then attempt to fix it based on convention or what they've done before. And again, tying back to that malpractice case, it's no wonder that up to 96% of medication alerts are overwritten, since clinician alerts are one of the most common solutions to changing behavior. And for those of us that do appreciate this process, our work can look like this, where we're aware of this process, but we get pulled around. We get pulled around by findings and limitations of the system. And so my experience in thinking is that scientific theories can help guide or bridge this process by providing us a starting point and some of these testable hypotheses. And this is really the primary point of my presentation. So most of you will know this, but I just want to make sure that we're on the same page. So a theory is as simple as an explanation of the natural world that has been repeatedly tested according to the scientific method. So it's a verified hypothesis. So Malinowski states that constant empirical verification, as well as original founding of scientific theory and experience, is obviously the very essence of science. So in other words, by using theories, we are putting science into our work. And I think this is a worthy cause and something that can be easily overlooked. So my logic is this. Many healthcare problems are wicked. And as others have done, wicked problems should be approached with a process and not a predetermined solution. And then finally, that theory or these basic truths can help guide the process of finding good solutions to these wicked problems. So for the remainder of this talk, I will demonstrate how I have used this process to create information displays for critical care, where I was focused on the health information technology and the artifact and the human-computer interaction. Then I'll show you how I'm using the same process to put theory into practice through health services research, where the information technology is just one of several components that will be implemented as a package to change behavior. Let's grab a drink. So as with any research project, it shouldn't be done in a vacuum. So these were my collaborators on this project. It was focused on the critical care information display. So I had a health services researcher, a health IT expert, a cognitive engineer, an intensivist, and a social psychologist. So this is a use case that motivated me to focus on critical care. So Just so happens to be my father-in-law's story as well. So just a few years ago, he had a successful coronary bypass surgery and was in good condition after the procedure. However, several hours after, his condition took a turn for the worse. His heart was struggling to keep his blood circulating, and despite various medications, he did wind up in cardiogenic shock. So as it turns out, he had an heparin-induced thrombocytopenia, which is an immune-mediated drop in platelets. So these platelets were essentially clotting on these newly grafted coronary arteries. Now there's a couple reasons why this condition maybe went unnoticed for a couple days. One is that he had rapid onset. He had had heparin from a recent procedure, and so the delay or the time from the onset was shortened. But also he was hooked up to a cardiopulmonary bypass machine that also depletes some of these platelets as well. So contributing to this atypical presentation, the intensivists were likely looking at an electronic health record similar to this, where you have a list of data elements on the left-hand side and then 9 hours of discrete values. And if, for example, you were looking for shock data elements, they're among other data that may not be relevant. And compounding this issue, where is the urine output, the lactate, the pH, the platelets? They're not on this screen. The clinicians need to go digging for these key data elements. And really the effort and cognition needed to combine these to identify trends could have contributed to how these clinicians missed this diagnosis. So what we know so far is that critical care is complex, and patients have overlapping and multiple conditions and little reserve for delays or misinterpretations for treatment. And unfortunately, errors like the one that my father-in-law had encountered occur quite often. And so I think that we can all agree that display or information display in critical care would be a really good problem. So I'm going to briefly go through each step of the process and give you just a peek into the theory that we used. So first, we needed to understand the space. And the way we did this was through systematic reviews of the literature. So we evaluated critical care displays in simulation and also that were implemented for patient care, and also displays that were for trend displays, or for trend information. So from the literature, we found that the best performing displays were on a single screen. They included graphical trend information, and they integrated patient information for pattern matching. So we started brainstorming derivative approaches based on our findings to see if we can meet these needs. So this first display is an object display. It's used to identify dangerous respiratory conditions. And what I mean by an object display is that the data elements such as inhaled oxygen and carbon dioxide are mapped to an object, such as the rectangle on the left and right hand side of this lung-like figure. But the idea is, as these related variables vary, it's easy to see changes or patient states based on the shape of that object. So this is another of those object displays. This one is for cardiovascular conditions. And again, the data elements such as central venous pressure and mean arterial pressure are mapped onto an object or rectangle type display. So these two object type displays, they do perform quite well on specific tasks, but they don't have trends, and they're not a whole patient view. So we thought something like this, where we have added trend information and then an object display as well. But the issue is this is also not a full patient view. You have some of these drop-down tabs. And also, this object display in the bottom left side is not integrated with this trend information as well. And then finally, this display was a full patient view. And I know this is difficult to see, so the point I'm really just trying to get across here is there's no trend information. But overall, most of these displays did perform quite well in simulation and some in patient care. So they would be, a viable starting place for us to start working towards. So we did some more thinking and some more digging and trying to figure out, which of these displays are currently used for patient care. And as it turns out, almost none of them are. So we tried to reframe this problem, trying to figure out, what is the issue? So it turns out that these displays were not really adaptable to other settings or for evolving patient care. So which makes these highly customized displays really obsolete after a while. So we came up with this idea that seemed to fit with what we found in the literature and seemed to fit with where we're going. And then the idea was these small, modular graphical components that display trend information. And we call these widgets. So these widgets can be grouped and organized, such as heart rate, respiratory rate, and other data elements for a variety of different settings, users, and it's also scalable for evolving patient care. So this is a conceptual diagram of what was done and our expected outcome. So on the left hand is this electronic health record display. So the information is in various forms and formats and it's scattered throughout, so making sense of this type of display is difficult. So the first step was to see if we could group and prioritize this information. So you can see on the second screen, there's less information and it's grouped together. And the second step was to see if we could widgetize and really optimize the display of these information components. And then finally, the third step was to integrate the group of these components together to see if this display could improve clinician performance. So the idea is that we would not only have these reusable components, but we can also validate these groups of components that could be placed into other displays, and all of this would maybe help lower some of these barriers to implementing graphical displays in different healthcare settings. So for this project, I'm going to introduce you to the first two steps and just a peek into the theories that we use for those. Then I'm going to delve a little bit deeper into that prototyping testing paper that we did for step 3. So back to our process. How can we group and prioritize this critical care information to enable this whole patient view? So we use chunking theory to give us a starting point. So chunking theory has roots in information processing and was first explored with chess players. So chunking is a process of grouping information into these meaningful wholes, which can increase our capacity to process information based on our working load, our working memory limitations. So the key insight from this theory that we applied to this analysis was that chunking was domain specific, meaning that these chess players couldn't go into the radiology lab and start identifying tumors. And also that chunking depends on expertise. So experts can handle a lot larger chunks with more complex information. So since chunking is domain specific and really depends on expertise, we recruited expert intensivists to sort these data elements into meaningful groups and then analyze these groups with a cluster analysis. So this is the paper that came out of this. So it's patient information organization in the intensive care setting, expert knowledge elicitation with card sorting methods. So the outcome of this was this concept map or hierarchy of data elements in groups. So we found that intensivists think about patients in terms of physiological systems, such as respiratory system, showing just a brief snippet of. But it's notable that the electronic health record doesn't store or present this information this way. It's similar to paper-based charts, so it's more source-based with medications and laboratory results. So now we know what information needs to be presented. We need to see if these widgets can now be used to display this type of information. So for this, we use the Gestalt Theory for prototyping and testing these widgets. So a good Gestalt is this simple description of the visual stimulus. So basically the gist of the visual. So one of the main concepts is this pieces to parts. So a piece is this randomly cut piece of an image, whereas a part is a part of this whole if that whole actually makes sense. So to illustrate this idea, I've got this hexagon, which is plainly a whole shape. Now the second shape has 17 sides. The interpretation is that there are 2 rectangles. But we don't interpret this as a hexagon with additional shapes. So the idea is that we wanted to show these clinicians routinely measured data elements such as blood pressure in various forms and formats to see which had the most accurate interpretation of the data. So the outcome was this analysis, or this paper. An approach to critical care information display, designing modular graphical components for presenting trend information. So basically, we took a very broad and diverse set of prototypes and distilled them down to just a few optimized widgets. So I just gave you a peek into some of these theories and the first two steps of this process of prioritizing the information and refining the display. Now I'll delve a bit deeper into the results of integrating the widgets together and testing the prototype. So we thought, what is a common and complex task that requires pattern matching, and we can integrate these widgets to increase clinician performance? So we use this proximity compatibility principle, which is a group of theories, to see if we could group these widgets to identify circulatory shock. So the proximity compatibility group is this group of theories that links visual information processing with displays to tasks. And especially with complex tasks that require multiple data elements, an integrated information display can increase performance. So integrating information together can be done, for example, by how close the data is together, and also other visual channels, such as color, shape, boundaries, that may link this data together. So to give you a better idea of this integration in task, on the graph we have task performance on the y-axis and then task complexity on the x-axis. Then the dashed line is the highly integrated display, and the solid line is this unintegrated display. So for complex tasks, more information integration increases performance. But if the task is not complex, the integration is not needed, and actually unintegrated displays and more focusing on these discrete data increases performance. So according to this proximity compatibility principle, there's a spectrum for integrating data together, which means how easily can patterns be recognized among multiple data elements. So for example, a pie chart has low data integration, and it's good for processing these independent variables. Whereas E, or these object displays on the far right-hand side, are good for processing their very high integration, and they're good for processing the multiple data elements. Now, our display is right in the BC area. So we sacrifice some of this data integration for flexibility, for different levels of tasks and complexity, and adaptability for changing healthcare environments. So what we need to prove now is that this type of display can now be used for complex tasks. So this is the paper, and this analysis is where we tested a group of widgets on this complex task. So impact of integrated graphical display on expert novice diagnostic performance in critical care. So identifying circulatory shock was our use case for this evaluation. And it ties into my father-in-law's case, and it's also a big concern for critical care providers as well. So nearly 1 in 3 patients will wind in critical care will wind up with circulatory shock, and it can increase mortality up to 80%. So circulatory shock is generally defined as a decreased blood flow and tissue perfusion, and is often formally diagnosed by hypotension and increased lactic acid. So early identification can help prevent organ damage and mortality. So these vigilant clinicians will search all over the electronic health record for signs and patterns that this may be happening, such as erratic vital signs, correlating trends that help them identify the circulatory shock. So there is a need for displays to help support clinicians in doing this task, such as recognizing, monitoring, and treating circulatory shock. So the research question was, can a display of widgets improve clinician performance on diagnosing circulatory shock? So we anticipated that this widget display would improve clinician accuracy and response time in diagnosing circulatory shock compared to a flow sheet or a conventional type display. We also anticipated that novices would have greater improvements with the widget display since they weren't quite as familiar with these flow sheet displays as well. So since chunking and information processing depends on expertise, we wanted to see if this integrated display that was already chunked and organized could help novices more. So this study was a within subject comparing different display types. So the integrated display consisted of these graphical widgets, and the conventional display was tabular, consisting of these discrete values. So we used mixed effects models to analyze the difference in outcomes between the two displays. And in the secondary analysis, we evaluated the display type by stratifying by expertise, so experts and novices. So we used 15 data elements for this, 4 physiologic and problem-based groups that included cardiovascular, respiratory, and infectious disease, and renal. And we got these from that first study where we identified the highest priority and grouping of these data elements. So this is a similar screen that the participants would use for this integrated display. So on the left-hand side are these tasks that we wanted them to complete, such as identifying shock and then selecting the shock etiology. And then on the right-hand side is this integrated group of widgets. Now there are several aspects of this display that increase data integration. So for example, the widgets are scaled to the same size. They also have the same 24-hour view. The top block of widgets were aligned in 2 columns with the most frequently used ones on top. And we also vertically aligned the widgets in the first column to help participants assess correlating trends and abnormal values at specific times. So the participant would advance this 24-hour window by 1-hour increments. And as these patient states would present, they would click on the corresponding task button. And for this scenario, this particular one was distributive shock, which typically presents with decreasing central venous pressure and systemic vascular resistance and increasing cardiac index. So for the conventional display, everything was the same, except we used a table of values for that display. So we analyzed 4 different outcomes: performance, latency, time, and etiology. So we define performance as the average of shock and no shock accuracy, meaning the proportion of correctly classified frames the patient was in shock and not in shock. And then latency was the delay of the frames from onset of shock to when the participant started identifying the shock. And then time was the number of minutes that it took the participant to complete that scenario. And then etiology is whether the participant correctly classified the type of shock that was shown in that scenario. So in total, we recruited 32 physicians from the University of Utah. And we balanced these experts and novices. Most of the experts were attending in each of the ICUs, and almost all participants provided patient care within 80% of the time. So these are the results. All right, so we have this integrated display here in blue. And what we found was that among all participants, performance significantly improved, meaning about 15% more of these frames were correctly classified with the widget display. And with etiology, or shock type, this was also significantly improved, meaning close to 20% more scenarios were correctly classified using this widget display. Now I know this is reversed. We have still a widget display in blue, but less is better. So latency among all participants was significantly improved was not significantly improved using this widget display. But the time it took to complete these scenarios was significantly better with the participants using this widget display. So with the exception of latency, the outcomes were significantly better using the widget display. So now when we stratified these results by experience, so experts and novices, there were some interesting findings as well. So we found that while experts seemed to improve using this widget display, only the novices had significantly improved. In fact, the novices' performance with the widget display was similar to the experts' performance using the flowsheet display. And for etiology, novices identified the type of shock 30% more using this widget display. And also novices using the integrated display had about the same etiology accuracy as the experts did using this conventional display. So I think the thing that's interesting and really adds face validity to these results is that the experts are used to looking at these flowsheet type displays to identify these patterns. These novices with the widget display perform nearly as well as the experts did with this flowsheet display. So I think his outcomes really demonstrate this nicely, the idea of potentially narrowing the gap between experts and novices through information display. So what does this all mean? So this means a few things. First, we were able to validate this proximity compatibility theory with an integrated display of widgets. So this was shown by faster and more accurate response time by participants using this widget display. And then second, this process of chunking information and refining this widget display may help compensate for undeveloped pattern matching skills among novices. And then finally, we demonstrated the effectiveness of a one widget set, but it's reasonable to think that these widgets could be regrouped with different tasks, and also additional data elements could be added as healthcare evolves. So the widget display may be this viable solution toward a widget problem. Okay, let's grab you really quick. So I just showed how I use design thinking and theory to create information displays for critical care. Now I will show you how I'm using the same process for putting theory into practice with health services research, where the health information technology was just one of several interventions. So again, research shouldn't be done alone, but the team has changed a bit. So this is a grant proposal that I'm looking to do for lung cancer screening in low-resource primary care clinics. So I now have a cancer researcher, an implementation scientist, a health services researcher, a health IT expert, and a general primary care practitioner. So this is surprising to me, but it may not be surprising to John. But in 2019, in the United States, lung cancer was responsible for the most cancer-related deaths, and was the second most frequently diagnosed cancer. And for the cancers that we routinely screen for, lung cancer caused approximately 58% more deaths in women than breast cancer, and about 142% more deaths in men than prostate cancer. So those are interesting numbers. So smoking is this leading cause for lung cancer. And unfortunately, these underserved populations have some of the highest rates of smoking. Also, these populations are less likely to be screened, and this together really causes this twofold increase in lung cancer deaths compared to higher socioeconomic populations. So the U.S. Preventive Services Task Force recommends a low-dose computed tomography or a low-dose CT scan for people who are currently smoking or quit less than 15 years ago, are aged 55 to 80, and have more than 30 pack year history of smoking. And what I mean by 30 pack year history of smoking is 1 pack a day for at least 30 years. So substantial smoking exposure. So now screening has risks of false positives that can lead to unnecessary treatment. So depending on patient risk factors, up to 95% of these positives can be false positives. So due to this risk-benefit trade-off, in order to get paid for a low-dose CT scan, you have to go through what's called shared decision-making. So it's this process of the provider communicating with the patient and really gathering the patient preferences and values to go through and pursue a treatment pathway. So due to shared decision-making and other barriers as well, less than 5% of patients that are eligible in the United States undergo this screening. And in these low-resource clinics that we're targeting in Utah, less than 0.1% are currently screened. So we had an idea. Let's get a killer application so these providers can perform this shared decision-making, and then they can bill for this service, and the screening will go up, and everything will be great. So we did this. We created an app. There was lots of data behind this risk prediction, the information was comprehensive, the visualization was in line with these other patient-facing displays, usability and informed decision-making, this app performed very well. So basically designers and testers loved it. But we thought that maybe we should test this in a live environment before saying this is a good solution. So while in practice, as it turns out, everybody hates this app. There's too much information. The provider said it wouldn't fit into their workflow. It takes too long to use. The patients hated it because there was too much information to consume while the provider was looking over their shoulder. So I'm not going to go into the process of how we streamline this application, but this is what it looks like now. So it's basically a single screen that has a risk prediction that stratifies this patient into one of these bins for discussion, and then it has quick and brief bullets to work through with the patient more quickly. So the bottom line is this. These primary care providers have about 1 to 2 minutes to discuss lung cancer screening. So from this simple finding, from prototyping, had reframed this entire health IT implementation for lung cancer to a lung cancer screening program implementation. So basically the question now is, how can we remove all of these barriers to make that 1 to 2 minute conversation meaningful? So our original funding opportunity was leveraging health information technology, so health IT, to address minority health and health disparities, which was really primarily targeted at this health information technology, and in our case it was that shared decision-making application. Now we are focused on a separate funding opportunity. So this is dissemination and implementation science for cancer prevention and control in low-resource environments. So this is mainly focused on this implementation strategy and this package of interventions. So we need to get some more information. So we started visiting clinics, trying to figure out what's going on. So after visiting the clinics, we found that there are lots of barriers. So as it turns out, they are gathering smoking status, but not smoking history. Most providers don't actually know the screening criteria well enough to identify patients. And patients face stigma and clinician bias with that connection between smoking and lung cancer. And most of the time, these imaging centers where these patients would have to go in rural Utah are further away than their primary care clinic. And providers don't have these tools, and I mentioned this before, but they don't have these tools to make this shared decision-making process easy and the documentation easy. And also, patients have other priorities they want to discuss, so lung cancer screening may be just down on the list. And then finally, these resource clinics may not have the extra resources for the personnel that may be needed to put in this lung cancer screening program. So to simplify this, I would say that a lot of these could be helped by removing some of these structural barriers. But I would say that there are some wicked problems in this list as well, with the stigma and provider bias and patient priorities being some of those. So one of the key differences between lung cancer and other cancers is this close link with smoking. So many people with lung cancer are blamed, or they blame themselves for this disease. So a good example of this stigma is from this Bloomberg News article that reads, "America's heaviest smokers don't want to know that they have lung cancer." But this stigma has been shown to prevent providers from offering lung cancer screenings to some of these most at-risk patients. But however, when we talked to these patients, we found, which was also consistent with the literature, that they were unaware of lung cancer screening, receptive to screening, and also open to being contacted about screening, and even some patients would consider quitting if they had a positive screening test. So getting back to our process. So with the idea of closing this gap between this provider bias and patient preferences, social influence theory seems to fit nicely and has lots of experimental studies that we can build from. So social influence is one of the most potent behavior change theories. It refers to the way that we change our behavior to match the social environment. So there are two key components that include internalization and compliance. So internalization is really adopting a decision by aligning your values to someone else's. And then compliance is this act of responding favorably to a request offered by others. So to illustrate these theories and apply them to this context, if we can get patients to internalize the idea that lung cancer screening may benefit them outside the clinic, then possibly the patients will come in and get their providers to comply with opening this discussion on lung cancer screening. So this answers the idea of what might work. The next question is, how are we going to reach this very targeted group of low-income, rural, heavy smoking patients? So this technology is not new, but it seems to be increasingly the best way to reach this population. Nearly all rural patients have cell phones, and approximately 70% of them have a smartphone with some sort of mobile broadband capability. I don't know if that's the same here. That is the case in the United States. So there's some data behind text messaging for breast cancer and colon cancer screening. And we also have a lot of data on how providers comply with patient requests. I mean, think about this direct-to-consumer advertising. It's a big thing in the States as well. What we don't have is how texting can influence lung cancer screening discussions. We also don't have a lot of data on how this smartphone capability and this functionality can help get patients more informed around screening. So my next prototyping and testing project is to gather pilot data and set up a study for when this project is funded. So I'm planning to prototype this prompt timing, such as before the appointment and after smoking status changes, the content such as exploratory or information gathering, how personalized or generic this message needs to be, and also how this interactivity can further information, and with further information this can help get these patients informed. So for example, this first message is more general, exploratory, to get smoking history, and then really to assess their responsiveness. The second message is much more personalized, contextual, with information that's gathered from the electronic health record. So the data on these contextual messaging is really mixed. I think some people think it's a little bit unnerving to see what sort of data others have on you, but others think that this sort of messaging is worthwhile because it shows the patient someone or something is going through their data. And then finally, short and sweet might be the best way, with more information upon request. So for example, if we can get them to enter some of their information into the tool before visiting the provider. So the idea is that we want to get this good balance of information so this patient will internalize this message and then bring it to the provider's attention. So overall, we want these patients to be educated about lung cancer screening and then empower them to discuss this with the provider. And then for providers, we want them to screen more by embedding these tools into their workflow for the patients that smoke. And we also want to give them these tools to facilitate the shared decision making as well. And then finally, we want to remove all these structural barriers, including training, transportation, screening data, to really cultivate the benefit from this 1 to 2 minute encounter. So this is my final slide. I know it's boring, but so overall, I hope you learned that healthcare problems can be wicked. Think back to that malpractice case where they were overriding all alerts. What about my father-in-law's case, where the diagnosis was maybe buried under a mountain of data? And then lung cancer screening, where this shared decision-making tool, which we thought would fix everything, just becomes one part of a larger solution. And then the clinician behavior is key to outcomes. So in each of my examples, I showed that behavior complicated the problem and was also a big factor. And then theories can guide this prototyping and testing solutions to change this behavior. And again, with each of those problems I showed, we applied different theories. And then finally, the next time you or others want to set up another pop-up alert to change behavior, please consider exploring other solutions as well. Thank you.